So we'll talk on blood transfusion and blood products in surgical practice. Now we'll use this outline in discussing the topic. And you should know blood transfusion is the infusion of blood or its products into the venous system of an individual for a therapeutic purpose. Now, when you talk on blood transfusion, it doesn't necessarily mean you are transfusing all the products or the whole blood. It might be packed cells, it might be any other component of the blood itself. So that is regarded as blood transfusion. Now, it remains an important tool in resuscitating a patient, okay, who suffers trauma, or optimizing a patient, a preoperative patient, before operating that patient. Now, indications for blood transfusion. When you talk on the indications for blood transfusion, the indication depends on the component to be transfused. And component transfusion is preferred to minimize the risk of complications. Now, when you talk about component transfusion, it's transfusing only the component that is deficient. Now, the blood components and their various indications. A whole blood. The indications for transfusing a whole blood is when there is sudden blood loss of more than 25% of blood volume. In exchange blood transfusion, patients who continues to bleed after receiving 4 units of packed cells. Okay, now what is fresh whole blood? Fresh whole blood is a blood that is collected and transfused within 3 hours. Both the collection and transfusion is all within 3 hours. And you should know that fresh blood contains all the components. All the components within the blood are viable. That is a fresh whole blood. Packed cells. How do you obtain packed cells? It's obtained by letting blood sediments and removing the plasma, or by centrifuging of whole blood at a rate of what, 2,000 to 2,300 for 15 to 20 minutes, or 3,000 revolutions per minute. What are the indications for transfusing only packed cells in patients with chronic anemia because they are prone to fluid overload? And what they require is only the packed cells. Elderly patients, children, patients prone to fluid overload, and cardiac failure, renal or liver failure. Major operation associated with clear fluid. You should know that 1 unit of packed cells reach the HB by 1 gram per dl in a 70 kg adult. So you should know 1 pint of blood raises the PCV by 3%, and 1 pint raise the HB by 1 gram per dl, because HB multiplied by 3 will give you the PCV of the patient. Now, platelet concentrate. It is the precipitate after platelet-rich plasma is centrifuged at 3,000 revolutions per minute. Platelet-rich plasma is the supernatant plasma after whole blood is centrifuged at 1,000 revolutions per minute. What are the indications for transfusing platelet? In thrombocytopenic patients undergoing surgery, aplastic anemia, okay, other surgical indication. And you should know that 1 unit of concentrate raise the platelet counts by 5 to 10 times 10 raised to power 9 per liter. Now, plasma, okay, is removed after centrifuging whole blood at 2,000 to 3,000, okay, revolutions for 15 to 20 minutes. It may be further fractionated into two components. Albumin, human albumin, you can derive that from plasma, or fresh frozen plasma. Human albumin, 4.5%, repeated fractionation of plasma by organic liquid, followed by heat treatment, okay? It's used for protein replacement, especially in severe burns. Fresh frozen plasma, plasma removed from fresh blood, obtained within 4 hours, is rapidly frozen by immersing in a solid carbon dioxide or an ethyl alcohol mixture and stored at -40 to -50 degrees Celsius. It contains protein, fat, carbohydrate, and minerals. The most important thing you should know about fresh frozen plasma are the indications. When do you need it? In deficiency of coagulation factors for which specific concentrates are not available. They are not readily available, or even if they are available in a center, they are extremely expensive. Even the fresh frozen plasma is expensive in our environment. I could remember a patient I managed that requires several pints of fresh frozen plasma. And when I prescribed, she secured each pint at a rate of 300,000 naira. And sometimes she will require 3 pints in a day. So you can imagine how expensive that could be. Now, emergency treatment of warfarin overdose and vitamin K deficiency. You can give a fresh frozen plasma. Okay, treatment of TTP and DIC. Now, cryoprecipitates. Precipitates when fresh frozen plasma is allowed to thaw at -40 degrees Celsius and the supernatant plasma is removed, you get a cryoprecipitate. It's rich in what? Now, for all these concentrates, you should know what components are in the concentrates, okay? The major factors that are more in that concentrate, like for cryoprecipitate, is rich in what? Factor 8, factor 13, fibrinogen von Willebrand factor, and it is stored at -40 degrees Celsius. It's used in hemophilia, okay, when there is factor 8 deficiency, hypofibrinogenemia, or von Willebrand's disease. Now, we've talked about indications for transfusing blood and their products, and you should all be conversant with those products and the various indications for transfusing them. Now, what are the criteria for donor? In collecting blood to transfuse to a recipient, you need a donor, and to select a donor, there are some certain criteria, which include the age. Patient should be 18 to 65 years and weighs over 51 kg. And the HB should be over 12 grams per DL or more in both males and females. No major operation in the last 6 months, no pregnancy within the last 12 months, no blood donation in the past 6 months, no clinical malaria in the past 1 month. Please, this is very important, not only because of your MCQs, but because of donation. When you are counseling patient for blood donation, okay? A patient should not donate blood and at the end and eventually is being harmed from donating his own blood. So no blood transfusion, tissue or organ transplant within the last 12 months. He should be free from severe hypertension, splenomegaly, hepatomegaly, bleeding disorders, or allergic conditions such as asthma. No vaccination in the last 3 months. Should be free from the following diseases: viral hepatitis, HIV, syphilis, trypanosomiasis, brucellosis. So any patient you are preparing for donation, you have to screen the patients. Now, the collection of the blood should be done under strict asepsis into a sterile plastic bag containing 60 ml of anticoagulant. Because if there is no anticoagulant, what will happen? It will clot. So the anticoagulant, you have CPDA, citrate, phosphates, dextrose, adenine. Of course, this citrate chelates calcium. And calcium is factor 3 that helps in coagulation. So when it chelates calcium, the blood will not clot. Okay? The phosphates, because this blood is stored, there is a lot of anaerobic respiration taking place. So the phosphates will, and formation of lactic acid. This serve as a buffer. Dextrose, you know, the red blood cells are obligate glucose users. They need glucose. So this provides energy, and adenine potentiates the ATP. So that's why these have a longer shelf life than CPD. Now, how is this blood stored? The labeled plastic bag containing fresh blood is stored as early as possible in special blood bank refrigerator, not your home refrigerator that will turn the blood into an ice. Okay, so at 2 to 6 degrees Celsius. So the temperature is set at that temperature. Now, you should know the reason why we prefer a fresh blood is because there are some certain changes that occur when you store blood. It tends to progressively lose its viability. What are the effects on the blood? The red cell swells by 20% and gradually loses potassium into the plasma. The viability of the cell diminishes as its ATP 2,3-DPG falls. About 1% of RBC is lost per day of storage. White blood cell platelets are not viable after 24 hours. Electrolytes, potassium rises at a rate of 1 millimole per day, and sodium concentration also rises. So if you have an old blood, what happens to the potassium content? It rises steadily. So if you are giving it old blood, it has a lot of potassium in it. Now, what happens to the clotting factors? Factor 8, factor 5 declines rapidly after 24 hours and no activity after 7 days. Factor 10, it loses activity at 7 days. Factor 9 and factor 7, they lose their activity at 14 days. Fibrinogen and factor 2, factor 1 and factor 2 lose their viability in 21 days, 21 days. The pH rises, okay? There is acidosis at 21 days. plasma, HP, and ammonium also rises. Now, how do you administer blood? As a house officer, you must know how to check and administer blood. Blood must be to be transfused should always be identified and checked against the recipient's name, blood group, hospital number, and the ward. Okay, the drip is set under an aseptic procedure using a wider gauge. Okay. Now, you don't just release and open for the blood to flow and rush, because the untoward symptoms usually occur during infusion of the initial 100 mils. The rate should therefore be initially slower at a rate of 20 to 30 drops, okay, per minute. That is 2 to 3 mils per minute. It is then increased after half an hour to 60 to 80 drops per minute after patient must have received 100 mils of blood and there is no any sign of complication. If there is blood loss, the rate of infusion should be rapid. If necessary, you have to squeeze the bag to rush the blood. In elderly and children, the rate should be slow to about 40 drops per minute or even less to prevent overload. Periodic observation, pulse, and BP should be monitored throughout. A standard filter should always be used. If you look at the blood giving set, it's different from the IV giving set in that it has a filter that prevents clots from moving into the venous system. Okay? Normal saline should be allowed into the same tubing, only normal saline. Okay? Now, hypotonic solution, you should know it lyses RBC, okay? And the calcium in the Ringer's lactate can cause clotting, okay? So, you should know transfuse 1 unit of blood or blood component should be complete within 4 hours so that you do not unnecessarily leave the blood outside the storage, because the longer it stays outside, the less viable it becomes. And also, the longer it stays outside, the more risk of transmitting bacteria, because there's risk of bacterial proliferation of microaerophilic bacteria. If transfusion must be given slowly because of heart failure, okay, the unit may be divided into smaller aliquots, and the rest that are not being transfused at that moment should be left at the blood bank. Now, this is a very important aspect of blood transfusion, the complications of blood transfusion. And of course, you should go back to your text and read the details of these complications and how to manage them. It is not just enough for you to identify a complication. You should identify a complication, the symptoms, how they present, and how to manage these complications. The immediate complications are febrile non-hemolytic reaction, and these result from pyrogens, which are usually white blood cells in the donor's blood that triggers fever in the recipient, or even from the materials that are used in the blood transfusion, like in the given set, pyrogens may trigger fever. Hemolytic reaction results from ABO incompatibility, and this results from clerical error. And of course, the mortality rate can be high, up to 55%, and patient will present with constricting chest pain, loin pain, okay, jaundice, darkish urine. They could have acute renal failure, okay? So you should identify this and be able to treat it, you hyperhydrate the patient, alkalinize the urine, okay? You have to even give diuretic like mannitol to prevent kidney acute renal injury, okay? And you have to regroup and cross-match that blood. Allergic reactions result from allergens in the donor's blood, bacterial contamination, microaerophilic bacteria that proliferate, or due to lack of aseptic procedure in the process of transfusion. Patient can suffer circulatory overload, especially those patients that are prone to fluid overload. So in such cases, you have to give them furosemide, okay, before or after the transfusion to contract the blood volume so that they don't suffer fluid overload. Patient can have cardiac arrest, okay? Now, this could be from several factors, maybe hyperkalemia, transfusing cold blood, acidosis, and so on. Air embolism, if you leave a lot of air columns in the given set, and this, as much as 10 mils, can cause cardiac arrest. Patient can suffer non-cardiogenic pulmonary edema, or transfusion is also called transfusion-related acute lung injury, TRALI. So you read about it and the cause of TRALI. The delayed complications of blood transfusion include thrombophlebitis, when you are transfusing using an old cannula, or cannula is left for a very long time. They can have thrombophlebitis, and this can be very painful and discomforting to a patient. Patients may develop delayed hemolytic reaction. Now, delayed hemolytic reaction results from some, it's not as common as acute the hemolytic reaction, because there are some antibodies of low concentration that builds up to a concentration that can trigger reaction. Post-transfusion thrombocytopenic purpura, iron overload, especially patients with hemoglobinopathies receiving multiple transfusions over time. It causes immunosuppression, transmission of diseases such as viral hepatitis, malaria, syphilis, cytomegalovirus, trypanosomiasis, brucellosis. What are the types of blood transfusion? Generally, blood transfusion could be allogenic or autologous. Allogenic is collection of blood from a donor and infusing into a recipient. Autologous is collection of blood from a donor and subsequently infusing to that same patient when it is needed. Allogenic transfusion, okay, or is called heterogeneous. This involves collecting blood from someone and infusing into another person intravenously. Autologous blood transfusion is the collection and subsequent reinfusion of patient's own blood. This method prevents transmission of diseases such as HIV, viral hepatitis, and avoids immunological complications of homogeneous or allogenic transfusion. Now, what are the various types of autologous blood transfusion? It could be preoperative autologous blood donation, acute isovolemic hemodilution, intraoperative blood salvage, and postoperative blood salvage. So you are expected to go to your text and read more on this and their criteria for donation. It doesn't mean I won't ask you in your test, so you should read about them. Now, this concept of massive blood transfusion is very important, and it is defined as the replacement of one or more of a patient's blood volume within 24 hours, or greater than half, 50% of the blood volume of a patient's blood volume in an hour. So you must be conversant with the definition of massive blood transfusion. If you are replacing a volume that is equivalent to a patient's total blood volume within 24 hours, that is massive, or half of his total blood volume within an hour. What are the indications? Okay, the most frequent indications is hypovolemic shock secondary to hemorrhage. And this could occur in severe trauma, ruptured aortic aneurysm, surgery and obstetric complication, massive GI bleeding, and in transplant like liver transplant. What are the problems of massive blood transfusion? They could come up with circulatory overload. They could have cardiac arrhythmias and arrests. These are caused either singly or in combination with the following. Now, cold blood can cause arrest. Hyperkalemia can cause cardiac arrest at diastole. Hypocalcemia can cause cardiac arrest at systole. Acidosis, these are factors, because if you are giving massive transfusion, there is no time to warm the blood appropriately and patient might go into arrest. They could have respiratory complication. Now, they could have bleeding diastasis, and these are, what are the causes? Because the blood you are giving do not have viable platelet, they are stored blood, so they will have thrombocytopenia. And the factors, as we saw, the various changes that occur in a stored blood, the factors, the clotting factors are not viable. So patient might come up with what? Bleeding after massive transfusion. They might have hypocalcemia because of the citrate content of the anticoagulants. You know, each bag has 16 mils of anticoagulant, and you are giving massive transfusion. Now, because of reduction in 3-DPG, there's reduced oxygen delivery of an old blood. Now, the next thing you need to know is alternative to blood transfusion. Some candidates, some people, some patients might belong to categories that do not receive blood transfusion. So you must have an alternative for them because of maybe religious belief, cultural belief, or a patient just refused to consent to blood transfusion. You must have an alternative. And this alternative could be autologous blood transfusion. Maybe patients reject other blood, but they can accept their own blood. You must have plasma substitute, red blood substitute, or even hypotonic solutions. Okay? Yes. Now, what are the plasma substitutes? The plasma substitutes are used to replace lost circulating blood volume in hypovolemic patients. The plasma substitutes are the plasma expanders, which include stable plasma protein, albumin, dextrans, synthetic gelatin, colloids. Now, red blood cell substitute, they could either be hemoglobin-based oxygen carrier, okay, diaspirin cross-link hemoglobin solution, okay, or perfluorocarbons. These are synthetic compounds that carry oxygen that can function as substitute for red blood cell, and they are not blood. Now, hypertonic solution like 3% saline, 7.5 saline in dextran, 70 dextran 70 and hypertonic ringas lactate have been used to transfuse patients with hemorrhagic shock. Now, in conclusion, you should know that blood transfusion remains important in management of a surgical patient. However, okay, not without its attending complications. Hence, should be transfused only when indicated. If you are to transfuse only 1 pint of blood, probably that patient might not need blood transfusion. Yes. It's also a need for alternative, okay, to eliminate the complications of blood transfusion. So we are going to We are going to entertain questions. If you have any questions, please, you can ask. Then I'll entertain questions.
Hello, Doc. Good evening, sir.
Good evening. How are you?
Fine, thank you. Thank you very much for the lecture.
You are welcome.
Sir, I need more clarification on this normal saline and blood transfusion. I just want to know, do we transfuse them together, or that means at the same time? Are they transfused at the same time? And are we going to use different veins in the transfusion?
Okay. This is a very good question. Yes. Any other question?
Good evening, sir.
You are welcome. Good evening.
Thank you. I have a question in regards to the blood donation criteria.
Okay.
Yes, for if normally if you are donating blood, they normally screen for, sometimes they screen for this other disease after you donating the blood. So I would like to know what happened to the blood that you donate. Does it become wasted, or it is still useful in, maybe there is an extract from the blood that will be useful?
Okay. Maybe they collected blood from HIV patients.
Yes.
Okay. Is it after screening, they notice it's HIV and they proceed to collect?
Yes.
Okay, if somebody told you that this blood is from a HIV patient, will you accept that transfusion?
No, Doc, I would.
Yes, you not accept. So it's wrong to even collect blood from any patient that's why you have to screen the patient before collecting. Okay, you can't go and collect somebody with disease and you go and get a healthy individual and infuse the disease. In fact, that is criminal. That is unethical. Okay, because
Yes.
any patient that is aware that this patient has a very serious illness and you are infusing hepatitis or HIV or products from anything that is unacceptable, it is unethical to use that for treatment. Okay?
Okay.
So those people
Yes.
that are doing it is wrong, okay, and it's unethical.
Okay.
Yes.
Thank you.
Question? Okay.
Yes, sir.
Yes, go ahead.
Yes, sir. So in the case of those who don't accept transfusion, maybe for religious beliefs, because of religious beliefs, I don't know what could be the alternative. Because you talked about autologous. If, for example, these patients maybe have a disease, maybe they have a problem, and we cannot transfuse another person's blood into them because of their cultural beliefs. So, sir, what is the alternative to rescuing such patients?
Yes, this is an excellent question. Yes. Okay. Any more question? Let me take the last question. Okay. Okay, let me attempt these two questions. There's no any other question. Now, the first question regarding infusion of normal saline and blood transfusion. Are they given together? If they are given together, are they given in different veins? This is a very important question. And for the person that asks this question, it shows that you are reading current textbooks, especially the Western textbooks. Now, this component blood transfusion, there is the concept of component blood transfusion where you transfuse only the component that is required. You don't use blood because it's a colloid to correct uh, low BP. If a patient has anemia, transfuse packed cells to correct anemia. Okay, then you give crystalloids along with that. That is a very current teaching regarding infusion of blood and crystalloid like normal saline and or Ringer's lactates. So you should know that they are given concurrently and they are given via different veins, and each has its own function. The blood there is to correct the anemia, okay? And the crystalloid builds up the plasma volume. And it is important to give it initially because it has better diffusion capacity into the interstitial space, okay, than colloids. Because if you give colloids, it tends to remain within the intravascular space because there is what is termed crystalloid colloid ratio, okay, 3:1. Okay, go and read about crystalloid colloid ratio. Okay, so in answering this, your question, you should know they are given. Yes, you can give normal saline and blood transfusion at the same time, but in that case, you are not giving a whole blood. You are giving packed cells to correct the anemia, and you are giving crystalloids to maintain the intravascular volume and at the same time administer electrolytes. And you use different veins. Hope that answers the question.
Yes, sir.
Then alternative to blood transfusion. Now, the Jehovah's Witness are a group of Christian denomination or sects that do not accept blood transfusion. There are two types, okay? There are some that accept blood products. There are some that will never accept any form of blood product or blood transfusion. They never accept. So if you have those that accept products, you have lesser problem. Now, if you have those that will never accept any blood or blood product, you have a bigger problem at hand. Now, there are some certain points you need to know. Number one, Jehovah's Witness have done extensive research on blood and blood products. So there is no any group of people that have done research on blood and blood products like the Jehovah's Witness group, because they don't accept blood, so they have all their alternatives. So they are so coordinated and they have a lot of network. They are networked in such a way that if any of their member requires a blood transfusion or product, they know how to get a product. So don't just go because you are a super surgeon. You just go, you want to save life and you just start transfusing it. You will be in a serious trouble. So number one, most of the time when they are coming to the hospital, okay, they come prepared, okay? They come along with products that can be transfused. That is in some cases, okay? And it will be written boldly on their case notes that blood transfusion is not acceptable by them. So they have a way of providing a product they need. That is one. Secondly, you should know that there are some alternatives to blood transfusion. You as a physician, assuming they come without any product, to save life, alternatives are classified into plasma, okay, substitute, and red cell substitutes. Now, the red cell substitutes are either hemoglobin-based oxygen carrier. They are synthetic. You can use or perfluorocarbons. So when they require blood, you can give them this product, okay, when they are available. And most of the time, you see them coming with this product. They know how to get it, okay? So when they require plasma substitute from this for anemia, but when they, or you give them some drugs like erythropoietin, the problem with this, it takes time to work. Iron, sulfates, okay. Some other drugs that can build the red cell. Now for plasma substitutes, they are crystalloids, which we mentioned, normal saline, Ringer's lactate, or colloids we mentioned. These are not blood, they are blood alternatives. You can use them to expand the blood. That is another point. So you use plasma substitute, red blood cell substitute. Then 3, okay, emergency situation, all these things are not available, okay, and patient insists that they don't want blood transfusion at all costs, and patient requires blood transfusion for you to save life. An option is to refer patient to another facility, okay? You have to refer patient if you can't do anything to save life. Patient insists, he's not giving you consent to transfuse blood at any cost, okay? It's unethical for you to go ahead and transfuse blood. Because you cannot manage that patient in your facility, you can refer that patient to where they can get all these alternatives. That is another point you need to know. You can also protect yourself by referring the patient. Number 4, when a Jehovah's Witness presents with a child, this child is less than 18 years, okay? It is now the parents that are deciding for the child that don't transfuse at all costs. So what will you do? This is not the child's decision, and you need to save the life of the child. When he gets to the age where he can make his own decision, he makes his own decision. So what will you do? Here you have to involve the ethical committee. The ethical committee of your hospital must be involved, where there are lawyers and all that. In fact, in emergency situation, this child must be taken off. They must be relieved of their parents to save the life of that child. Why? Because it's a minor, and that child cannot make his own decision, okay? When he grows up to the age where he wants to be a Jehovah's Witness or any other form of denomination he wants to become, that is his own choice, but you cannot make choice that will be detrimental to the life of a child. So here you have to take action, okay? And you don't take action on your own. You must have backup, okay? Here the states will be your backup. Yes. Hope it's clear.
Yes, sir. Thank you.
Yeah. So any other question? So I believe we don't have any questions. So please